my understanding has been brought to my attention that there won't be any Republicans here today, so we checked in with the staff of the minority party that it's okay to get started as a sub. Assuming we get a quorum, we will interrupt whoever is presenting at that time to establish that. If, for whatever reason, we don't have a quorum because we only have 2 bills, we'll go immediately after that into the next subject matter, which is obesity in California. At that time, once we establish a quorum, we'll go ahead and interrupt, take a vote on the 2 issues. We have 2 bills. I will be presenting for Assemblymember Marucci. So we will first start off with item number 1, AB 369, PAN, continuity of care. It is an urgency measure. Won't be affecting this committee, but on the floor it will be a majority of, a 2/3 vote at that point. So with that, Assemblymember, welcome, and please present.
Thank you. Thank you, Mr. Chair and members. AB 369 is a bill that provides someone who's in the midst of certain types of treatment, such as treatment for cancer, with his or her individual health insurance policy when it was canceled because of the new patient protections of the Affordable Care Act, or because the insurance company withdrew from the market, an opportunity to remain under treatment with his or her existing provider through the completion of that treatment, if the provider and the new insurance company can agree to their payment terms. I have amendments that revise this bill to reflect negotiations with stakeholders. A mock-up is being passed out. An amendment specifically restore language that protects patients from being billed for amounts beyond copays and deductibles, makes it clear that the physician's agreement to accept an insurer's terms to care for a patient under this bill cannot be construed as an agreement to accept those terms for other patients or services, and makes clarifications requested by the health plans, insurers, and the Department of Managed Health Care, and details can be found in this analysis.
Do we have the amendments in front of us? Have they been passed out in a mock-up form? Can we pass? Okay, because I don't have a copy yet.
Oh, you don't have a copy? Okay.
If the sergeants can get me, or because my understanding is this all came together at the 11th hour, but.
Yes.
But I want to make sure it's in front of everybody.
I'm sure all the committee members have them. Okay.
All right, proceed.
Oh, thank you. Thank you, Chair. We know that approximately 900,000 people in California have been affected by cancellations, and another 50,000 have been affected by company withdrawals. A large majority of those people affected will be getting better, in many cases cheaper insurance coverage because of the Affordable Care Act. Unfortunately, a small percentage of patients who are in the middle of treatment for acute or serious or terminal conditions or pregnancy may be enrolled in a new insurance plan that does not include all the providers that are currently treating them for those conditions. This bill has been introduced to allow a person in this situation to request that the new plan cover the services by the non-participating provider through the duration of treatment. The provider is under no obligation to continue with the treatment or accept the new plan. If the provider does not agree with the new plan's arrangements, he or she can make other arrangements with the patient. Ultimately, though, this bill will help these patients complete the treatment that they started. This bill builds on existing continuity of care protections that were put in place over 10 years ago to deal with situations where insurance companies were terminating contracts with providers in the midst of treatment of patients with acute, serious, or terminal illnesses or pregnancy. And I have witnesses here to speak in support. Thank you.
Thank you. State your name and your position, please.
Beth Capel on behalf of Health Access California. We're pleased to be the sponsors of this measure. It builds, as Dr. Pan said, on existing law that applies in the employer market. Before the enactment of the bills that you, Mr. Chair, and Dr. Pan carried to change the rules in the individual markets, it was inconceivable that somebody in the midst of chemotherapy or a pregnancy or other serious care could actually change their providers. Now, as a result of the Affordable Care Act and as a result of your legislation, consumers can actually change their insurance plan in the midst of very serious care. This will allow them to continue to see their doctor in order to complete or transition their care. We think these are very important consumer protections that should apply in the individual market just as they do for people with employer coverage. We have been pleased to work with the plans, the insurers, and the California Medical Association on making sure that this will work in the new environment, and strongly urge your support of the measure.
Thank you. Anyone else in support?
Bill Barcelona, CAPG Physician Groups. We are also in support of the bill. The law has functioned very well for the last decade in group-sponsored coverage, and it will apply now with these amendments to the individual market very nicely as well.
Thank you. Support?
Vanessa Kahina with the Western Center on Law and Poverty, here in support.
Thank you.
Holly Lanebean on behalf of March of Dimes in support.
Mike Montgomery, Congress of California Seniors. We support the bill. Thank you.
Thank you.
Hi, Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies. First, I'd like to say we appreciate the author and sponsor and all the staff's hard work on this issue. I know that we had a few outstanding concerns with the bill. As it stands now, while we don't necessarily think that C is necessary, we do think that we are neutral on the bill. We'd like to benchmark that our legal counsel just got the amendments last night, so we'll be looking at them, but we think in concept we're comfortable with where the bill is today.
Thank you.
Nick Luizos on behalf of the California Association of Health Plans, essentially reiterating ACLIC's statement. We want to thank the author, sponsor, your health committee staff for an honest discussion around this issue. Things on the Knox-Keene side as they pertain to Knox-Keene license regulated HMOs look pretty clean. Obviously, there are some new amendments impacting the insurance code, but ACLIC has already addressed those in their statement. So we don't have a position on the bill and want to thank the author for working with us.
Thank you.
Thank you, Mr. Chair. Juan Thomas, representing California Medical Association. We too would like to thank the author of the bill, the sponsor of the bill, and the staff in both committees for working on the bill with us. We have a neutral position on the bill. And again, we'd like to thank everyone for working on the bill.
Thank you. Any opposition? Any questions or comments from any of the members? Seeing none, we don't have a quorum at this time. Assembly member, would you like to close?
Well, again, I just want to reinforce this is a very narrowly crafted bill that applies only to individuals in the midst of treatment for certain serious conditions and only to individuals whose coverage was canceled during a 4-month period due to higher standards created by the ACA. As you heard, we have worked extensively with stakeholders. It is important that the bill move urgently so that patients in the middle of a health crisis, essentially at the beginning of 2014, which is now, do not have to face treatment disruptions. I respectfully ask for an aye vote, this important measure, when you have a quorum. Thank you so very much, Mr. Chair.
Thank you. As I said, once we establish a quorum, we'll ask for a motion. At this point, we will move on to item number 2, but thank you for the presentation. The Assembly member who's carrying AB 1124 asks that I present. At this point, I will turn the gavel over to Senator Wolk. And
all right, we're moving on to item number 2. That's AB 1124. Mr. Chair.
Thank you, members and Chair. This bill would provide a time extension for the Department of Healthcare Services to develop a new rate methodology for reimbursing clinical lab services under Medi-Cal. The HCS was directed to create a new way to calculate these rates in the 2012 budget. While the department has made progress in bringing together stakeholders and collecting the necessary data, it will not be able to complete the process by the April 1st, 2014 deadline. The sergeants are distributing authors' amendments to delay the date by which the DHCS has to adopt emergency regulations. The author is making this change at the request of the department, and with that, I respectfully ask for an aye vote.
All right, witnesses in support, welcome.
Hi, Christian Foy here on behalf of the California Clinical Laboratory Association, and we want to thank the Senator for bringing this bill forward. We are the sponsors of the bill. The California Clinical Laboratory Association has been working closely with the department in the implementation of this program. We've attended various stakeholder meetings, and all of the clinical labs submitted the required data as of May of last year, but due to kind of unforeseen circumstances, it's taken a lot longer to implement the program, and the department has let us know that they will not be ready to implement the new rate methodology by this summer when some of the key dates expire. And so that's why we have this bill, which would extend the timelines that are required under the program. Thank you, and we ask for your support.
All right, thank you. Witnesses in support.
Madam Chair, Don Gilbert representing Quest Diagnostics in support, and also just want to thank committee staff for all their help with the bill.
Okay, further witnesses in support? Witnesses in opposition? All right, seeing none, questions from the committee? All right, Mr. Chair, we have to wait for a quorum. Would you like to close?
Just ask for an aye vote, Madam Chair and members.
All right.
All right, we're going to go ahead and establish a quorum. Secretary, call the roll.
Hernandez.
Here.
Anderson. Bell. De Leon. DeSaulnier. Evans. Monning. Nielsen. Wolk.
Quorum has been established. Item number 1, is there a motion? Senator Wolk moves AB 369. The motion is due pass as amended to appropriations. Call the members, please.
Hernandez.
Aye.
Aye. Anderson. Bell. Bell, aye. De Leon. DeSaulnier. DeSaulnier, aye. Evans. Evans, aye. Monning. Nielsen. Wolk. Wolk, aye.
Okay, that currently has 5. We'll put that bill back on call and lift it when the remainder members arrive. We're going to move on to item number 2, AB 1124. Is there a motion? So moved by Senator Wolk. Motion is due pass as amended to appropriations. Call the members, please.
Hernandez.
Aye.
Hernandez, aye. Anderson. Bell. Bell, aye. De Leon. DeSaulnier. DeSaulnier, aye. Evans. Evans, aye. Monning. Nielsen. Wolk. Wolk, aye.
That has 5, enough to get out. We'll put that bill on call, and that dispenses with the business of the 2 bills. Okay, we're going to go ahead and lift the call on item number 1. Call the absent members.
De Leon. De Leon, aye. Monning.
Yes.
Monning, aye.
That currently is 7. That bill is out. We're going to move on to item number 2, AB 1124. It's a due pass as amended appropriations. Call the absent members.
Anderson. De Leon. De Leon, aye. Monning. Monning, aye. Nielsen.
That has 7. It's enough to get out. As I mentioned, the Republican members aren't here today, so we'll go ahead and close that roll. So that concludes the business for the bills. We're going to move on to the subject matter of obesity in California. It's an informational hearing. A couple of remarks I'd like to open up with. I'd like to, first of all, thank all the presenters who are going to be presenting this afternoon on the issue. And the reason why we're doing it is throughout the year we're going to do a series of hearings, informational hearings on cost containment, on obesity, but to get to the point of trying to figure out how we're going to reduce cost in chronic disease management, and what are the biggest cost drivers that are in our healthcare system. Some of the biggest, obviously, could be diabetes, high blood pressure, heart disease, asthma. But obviously, two of the biggest, which is high blood pressure and diabetes, have a direct link to obesity. And how do we control obesity rates here in not only in this country but in California? But the biggest concern to me is child obesity rates. Because as we know, as children, if they're obese as children, as they become adults, have a higher incidence or propensity of becoming diabetic, and therefore costing the healthcare system even more. So today's hearing is going to be gathering information on obesity as a whole, what it's going to take to reduce that, and then how do we formulate thoughts and legislation from this point on to address the cost drivers here in the state of California. So with that, I'd like to offer, if there's any members that wanted to make any opening comments at all. You see none. What we're going to do is we're going to start off item number 2, an overview, obesity epidemic in California. We have Patricia B. Crawford, PhD, and we have Dr. Robert C. and Veronica Atkins, Center for Weight and Health, University of California, Berkeley. So can we have the first presenters come up and proceed? Welcome.
Thank you very much. Chair Hernandez and the other distinguished senators for inviting me. I'm very happy to be here. I wanted to present you with an overview. I am Pat Crawford at the University of California at Berkeley, Director of the Center for Weight and Health, Cooperative Extension Nutrition Specialist. And I have been on many National Institute of Medicine committees, and I will share with you some of that information that the National Academy of Science is also providing in the form of Institute of Medicine committee workshops. So with that, I thought I would begin here with a little bit of the Center for Weight and Health, because we're located here on the there at Berkeley campus. For the express purpose, the center was developed to really synthesize the information, provide it back to constituents and those in communities and government, work in partnership with others, like on those committees, evaluate programs and policies, translate, and conduct research on evaluation, which we think is really the way that we can get the most action in this area. So today I'm going to talk about the rates, but primarily focus on the context. So you've all seen the maps, but I'm going to provide a little context for the maps of how obesity, this is what we tell the students, this is the definition of an epidemic, how it increases with increasing numbers every year. And it's always fun to see, visually rather than just the numbers. But let me synthesize this for you. So this is a self-reported data in the United States. It's the only data we have on obesity that we have for states. We don't have measured data comparing one state against the other. But I think the thing to look at for California was how many years we were at the same point. So for 6 years of measurement, we are less than 10% of our population in California was obese. And then for 6 years, 10 to 14%, it grew. 6 more years, 15 to 19, it grew. 20 to 24% for 9 years. So we're beginning to see a slight slowdown, but the latest data shows that we've gone up another category. So it's still going up, but it may be slowing for adults. California, related to the U.S., our obesity is slightly lower, but when you add in all of those who are overweight, our rates are higher than those in the United States. And part of this is because of the differential rates for those who are Hispanic and Black, that they're higher rates. So the same thing is true for children. We have slightly higher rates in California, and these are low-income children, and this is measured data. So it's, there's more precision in this early data that's coming from WIC and low-income medical visits, where the physicians keep records and send it in for the PEDNAS database. So it's slightly higher in California. And the CDC used to compile all of this with us, and we're really missing that information now because they've now left it as a state responsibility to follow low-income children and the rates of obesity. But this is terribly important given the new information that early is critical if we're going to really address the obesity epidemic. So it's really important to have a functioning data set for the state of California. So that's one request and thought I have that I think is relevant to what you do. Of course, by race, it's very similar than it is for adults, that blacks and Hispanics have higher rates. So the more concerning thing is that we're one of the states documenting that as obesity in childhood is improving, the disparities are actually increasing. So that is very troubling that we're widening the disparities as we improve certain segments of the population. So one of the things that we always need to keep in context is we have higher levels of Hispanic children, and particularly in California, as you all know so well. So those rates, if we adjusted by race, California would be doing better. But the cautionary, and the same thing with income, the cautionary issue there is that even though we may be better than other states because adjusted for our racial composition, you know, our rates would be slightly better than the average. But the fact is that none of the states are doing well enough. As those other charts showed, we need to improve, and there's lots of promise here. So in California, we have the best data set to look at child nutrition rates for 5th, 7th, and 9th graders that started in 2001. We have an amazing data set to show how things are changing in California. And I'm just going to give you a sampling of this by boys, girls, and different races. But this is the slope of BMI for children in the state of California, given the 5th, 7th, and 9th are the 3 grades that we're collecting. So this is a combination of all those children, millions of data points that we analyzed a few years back. And we now have the new data set, so we're going to be expanding that by 3 in the next month or so. But let me just show you that, because this is terribly important, that we're seeing that the upward trend that started in the beginning of the 2000s, actually started in the 90s and the 80s, is now beginning to level. Hispanic boys, it's also beginning to go down. Asian boys, American Indian boys, we think if that continues, that will be very promising. These are the white boys. The girls, the black girls, we're seeing a steady, slow rise. Hispanic girls beginning to go. American Indian girls climbing. So, and white girls are down there with a slight decrease as well around the 2005. So what does this mean? This is the data for the 5th and 7th graders, just all the races combined, both genders, and this we published in the Policy Journal as the first state in the country to show that after a given policy, this of course was the sodas out of schools that happened in 2005, that it is likely, we can't attribute it, you know, because we didn't, you know, do a randomized control trial on this, but every, all the folks who do policy say that this is as good as it gets when you look at all the different timing for those different groups converging at that period where we were changing policy in the state of California. And of course, this is confirmed by the number of calories. We did studies at the Center for Weight and Health showing how many sodas and sweetened beverages went down. And that was very important because people suggested that if we didn't look at the whole day, that kids might be having more before school, after school. Well, that in fact is not the case. It went up a little bit, but it went down so much at school that made a difference. So we are going to be following that with great interest, with continuing to follow that. We see here the numbers, the 18.9% obesity in California in children, up to 23 and down to 22.4. So that's that little the little blip that you saw with all those other charts. So let's look at the medical costs just briefly. I know you're going to have a speaker on costs, but we just did this one here at the Center for Weight and Health, looking that if those lines continued to 2015, and that's what we will be checking in the next 2 months because we just got the new data set from the Department of Education on FitnessGram, and if we even assumed a minimum saving of $220 per child, which is a conservative estimate about the increase in healthcare costs for an obese child, that we have just saved from that legislation in 2005 over $20 million. But more importantly than that, we've saved 100,000 children who would be in the obese category right now if it hadn't been for that soda and that sweetened beverage at school. And that is certainly what we think has turned this, has begun to reduce those curves. We're one of only 4 states in the country that's had a statewide reduction. The other states, and I know you'd ask, Mississippi, New Mexico, and West Virginia. Many cities have seen reductions, like New York City and Philadelphia, places we hear about, but statewide, we're in a pretty unique situation right now. So we're one of the reasons, because we have about 1/8 of the children in California, we're one of the reasons why we're now saying in the United States, we're beginning to see a leveling in childhood obesity. So the actual, if you want to see how we did the calculation of over $20 million, that's how it is by race. Certain races we haven't, the African American girls and the American Indian girls we're not seeing a savings in those, areas because they haven't gone down. So some in girls, but way more in boys that are no longer in the obese category, given the slopes of those lines continue. So that's a over $16 million savings right there. So, but beyond the financial piece, it's so important that we do think about the human cost of obesity, because I think this right here is the most important slide I show in any of my presentations. And I keep it kind of vague, so it's a little bit mysterious. But in 2001, this was the N. Haynes study, which is the measured study of obesity in the United States. So it's not by state, it's the whole United States. It's a randomized sample. It's the biggest sample, the biggest database we use for everything regarding disease in this country on what's happening. In 2001, adolescents in this country, 9% of them were pre-diabetic or diabetic. So 9% are on the cusp of diabetes in 2001. In the same period where we're beginning to see slight leveling in obesity for children, in 2009, that had gone up to 23% of the adolescents in this country. I mean, that's absolutely unheard of in the world. This was a disease that wasn't around, and now we're seeing 23, nearly 1/4 of them with blood values that are right on the edge of diabetes. So I always, when I'm talking to a public health audience, but especially when I'm talking here, I always say, how high does that number have to be before we take some very aggressive action? And I took the liberty of doing up a fact sheet on sugar-sweetened beverages for you all, because that is the single most important food or beverage, anything, if we're going to touch that we can do. So we need to really think about the newest research. That's why I did up the fact sheet, because since you discussed this a few weeks ago, we now have even stronger evidence. So it's going to be, we're going to really have to address that and figure out how high that will go before we actually take some bold action. And I always tell people that when they talk about how regressive the policy is, I say, well, the heart disease and diabetes are even more regressive. So we have to deal with the disparities. And of course, with adults, about 1/2 of the adults in the United States, the same thing with measured values, are either pre-diabetic, diabetic, and worse than that, many of them are undiagnosed diabetics, which have even greater health risk. So the cost is great. I show them in the 70s when many of us were much younger. This is a picture of what kids looked like. And now, when you look at our diverse state, this might be a picture of children in California, and with the 3 circles, that's that 1 out of 2 Hispanic and Black children will become diabetic in their lifetime if we don't change those obesity rates below what they were in 2000. We have a long ways to go, but I think what we've shown is that we can do something about it with policy. So I'm going to end with what I think are the key messages is that we have to invest in prevention with policies and with really strategic thinking about how to do it. We have to create a culture of health so that when we are doing things, we get the synergy from doing workplace, working with schools and childcare, which we know is critical, and you're doing some wonderful things in those arenas. And then I put utilize the resources of the university, because that's us, and we want to be called on to provide the most recent and up-to-date data. And I'm with Cooperative Extension, and I see this as my mission to really educate the public. And we have now, at the Office of the President, outside of our Center for Weight and Health, a new institute called the Nutrition Policy Institute has been established to help inform policies, evaluate policies, provide information to policymakers. So I do want you all to know that this is starting on February 18th as a new effort by the University of California to be more involved and really, have better exchanges and more rapid feedback in a more timely way when you do need information. We want to be, helpful in this most important mission, and I do appreciate that you're taking this on, and thank you very much.